This morning. For those of you who don't know me, I'm Scott Vogel. I'm one of the attendees, obviously. I do mostly neuro, but today we're going to talk about inhaled anesthesia, which is ironic because I actually don't use a whole lot of inhaled anesthesia on neuro. I promise, I know how to do it. Okay, so how do our inhaled anesthetics work? What do you guys think? D. Yeah.
C.
Yeah, so it's a little bit of C, it's a little bit of art. The truth is that it's D, we don't exactly know. So look at this headline from Newsweek. This is in 2018. It literally says scientists have no idea why anesthesia works.
I saw that. It was kind of insulting.
Yeah, it's a little bit insulting. And I wouldn't say we have no idea. I would say we have some idea.
Yeah.
We're getting there. But,
Anesthesia is a broad word.
exactly, right?
It's an example of fake news, everyone.
Yeah.
Yeah.
Don't read the internet. Alright, so you guys maybe have heard this. So there's a couple different theories out there. This is the lipid solubility theory. So what this says is that if you look at lipid permeability and anesthetic potency, they seem to correlate when you look at them on a logarithmic basis. But the truth is that olive oil does the exact same thing and doesn't have any anesthetic potency, as well as some things like temperature. So if you heat a lipid membrane up, it will actually become more permeable and doesn't cause anesthesia. So those obviously are not anesthetics, and so this is not kind of a one-size-fits-all thing. The next thing is a protein binding theory, which is probably more the direction that we should go. And this is looking at luciferase inhibition, which is a firefly enzyme. There also appears to be a long chain alcohol cutoff. And what this basically says is that if there's a pocket that these anesthetics work in, if the molecule is too big, it won't fit in the pocket and hit the receptor. So this really supports kind of protein binding receptor theory. The question is what sites are there? Basically, I'm going to throw out every single potential presynaptic and postsynaptic thing for you, but the most important thing seems to be GABA. So where do you guys think our inhaled anesthetics work? C. Yeah, it's probably both, okay? So if you look at spinal cord, so they actually did these experiments in rats, which sounds kind of terrible, but we did cryotranssection of the cord in rats, and it actually affects their ability to respond to anesthesia, meaning it changes their MAC level. So there seems to be some element of descending control, right? So the brain has descending control of the spinal cord, and if you cut that, there seems to be a change in MAC. You can also selectively give anesthesia to the torso versus the head of a goat. So fun fact of the day. So goats don't have internal carotids or internal jugulars. They have an external of both, and they don't have any vertebral contributions. And so it's really easy to just isolate a goat's head. You just cannulate the external carotid and the external jugular, and that's it. Anyway, the point is that you can do that, and there seems to be some interplay between them. So it's not like if you anesthetize the spine, the animal is totally under anesthesia, versus if you anesthetize the brain, they're totally under anesthesia. There seems to be a combination of both of those things. If you look at the brain, when you give anesthesia, what you'll see is you'll see changes in blood flow as well as changes in metabolism. You'll see EEG changes, and you'll see certain parts of the brain, particularly your thalamus and your midbrain, that are more depressed than others. And so the thought is that your spinal cord really is responsible for that immobility and analgesia, whereas your brain is more responsible for the hypnosis and anesthesia part of it, which makes sense because your spinal cord has kind of those primitive interneuron reflexes. Your spinal cord is actually capable of making pretty complex reflex motions. And so you guys have probably seen a brain-dead patient perform a pretty complex motion, and then that's simply a spinal cord reflex. And so when a patient responds to anesthesia and they're awake, it could be just a spinal cord reflex, because it is possible to have a complex reaction to that. All right, this is kind of the chemistry part. So what factors affect gas uptake?
All the above.
Yeah, all the above. Okay, the answer is always all. It's always all the above, okay? That's because we're pathetic at writing questions. All right, so uptake is solubility, it's cardiac output, times your AV gradient, which makes sense, right? So the first thing is that uptake is not the same as onset, and that's important, okay? So this is sort of like the fill the tank, and then you'll see the results type of picture. So the way I think about it is inhaled anesthesia is soluble, and you have to saturate the blood before you start getting anesthesia affecting other parts of the body first, okay? Because if it stays in the blood, that's great, that's dandy. It goes places, but then it still stays in the blood, and we don't anesthetize the blood, we anesthetize most likely the spinal cord and the brain. Okay. So solubility is reflected by the blood gas coefficient. So does anyone actually know what a blood gas coefficient is? Like, what does it mean to have isoflurane 1.4? What does that mean? So it means there's 1.4 times as much isoflurane dissolved in the blood versus the gas. Okay, so fun little fact. You can see some of our older, kind of more vintage anesthetics, methoxyfluorine diether, with 15 and 12. I'm not sure what some of the ones used back in the 1930s were. I'm sure they're even higher. The take-home point here is that low solubility leads to quicker inductions and quicker wake-ups. Okay, so if the molecule is not soluble in the blood, it's not going to have to saturate a big pool of blood before it starts acting your peripheral tissues. Okay, here's kind of the tricky one in my mind. So cardiac output. The thing with cardiac output is obviously blood flows past the lungs, blood is taken up, or anesthetic is taken up into the blood. The thing is that if you have a low cardiac output state, I think of it almost like stagnant blood, and when it passes the lungs, it gets filled up really quick. And so what happens is that low cardiac output states are actually anesthetized a little bit quicker than high cardiac output states, which is a little bit counterintuitive. But it kind of goes, this is more of like a vintage thing, but halothane was really bad for your heart, okay? It caused a lot of myocardial depression. And so what happened was that you get uptake of halothane, which would cause a decrease in your cardiac output, which would cause an increase in your uptake, which would increase your speed of induction, which will then further increase your myocardial depression. And it's this really bad cycle loop. With our modern anesthetics, it doesn't happen quite as much because of the decrease in solubility. But the take-home point here is that low cardiac output states paradoxically lead to quicker inductions. Okay? This is, I think, the easiest one. Okay, so if your AV gradient's high, meaning if there's a lot of gas in your alveolus and not a lot of gas in your blood, it's going to make that work a little bit faster, okay? Because we're simply going down concentration gradients. There's no active transport of anesthesia. So the take-home point here is that the more gas you use and the more you ventilate, the quicker they're going to be induced to wake up. Okay, you guys have all seen this chart in some type of anesthesia book at some point. This is the FA to FI. It's also the FE to FI ratio chart. This is the clinical equivalent onset. And the question here is, why is nitrous the fastest when DES has a lower solubility? I don't want you to answer that because we're going to come back to that in a second. And then the last thing kind of affecting onset is shunts and dead space, right? So VQ mismatch is a generic term for shunts and dead space, right? Because VQ mismatch is a continuum. On one side, you have ventilation and perfusion. What's that called? Right? And the other one, you have perfusion and no ventilation, which is shunts. Take-home point here is that if you have a cyanotic shunt or dead space, those do affect your induction. But the soluble drugs are affected less, which, again, kind of to me makes sense. It's like, okay, well, if they're really soluble, if you get some blood past the lungs, fine, it still worked out okay. These are kind of things that you just have to kind of get straight in your mind because they make for really good test questions. Unless you're doing like congenital pediatric cases where you're doing mass inductions on kids with like right to left, left to right shunts, doesn't play a big role in adult anesthesia, okay? But like I said, good for test questions. I rewrote this slide last night, and I'm sorry that it's so small. But this is important, and I think it's important for you to hear once and then kind of lock in your brain. So you've heard of the concentration effect. So the question is if DES and nitrous have the same blood gas partition coefficients, why is nitrous quicker onset than DES? This is the classic chart. And the answer is, this is the concentration effect. Okay? So the concentration effect works like this. Basically what happens is that you have a combination of gases in the alveolus. And some of that gas is absorbed into the bloodstream and then replaced by the gas behind it. Okay? And if you look at the math there, you go from 80% nitrous down to 67% nitrous, back up to 72% nitrous. Okay? And that's just simply being, you're going to absorb nitrous, you're going to have a void in that alveolus, which is going to be filled, aka augmented gas inflow. And then you're going to end up from 80 to 72. Versus if you're 20 parts nitrous, you go from 20 down to 11, back up to 12. check my math there. I don't think I made a mistake. Okay. So what percent is 72 of 80?
90.
90%. What percent is 12 of 20?
60.
60. Okay. So basically, with one gas exchange, you're going to have one situation where you're going to maintain 90% versus the other one where you maintain 60%. Meaning, if you use a higher concentration of nitrous, you're going to reach a higher FA to FI ratio quicker. That's why nitrous is faster than DES at onset. It's the stupidest thing in the world, I know. But seriously, these make for really good test questions as well. Okay, for most of the gases, these don't make a difference. For nitrous, it does because we use such high concentrations. So the answer on the test question is, they ask you, why is nitrous faster than DES? It's because of the concentration that you use of nitrous, aka the concentration effect. Okay? Very similar is the second gas effect. Okay? So the second gas effect is when you use a combination of nitrous plus another inhaled anesthetic that kind of tags along for the ride. And as you can see, if you start off with 2% inhaled anesthesia, after one cycle, you're up to 3.1, then down to 2.7. Okay? So you go from 2 to 2.7. So this is a way to get a higher concentration of inhaled anesthetic as compared to what you simply set in the vaporizer. Okay? So this would be a situation where you have like SIBO plus nitrous plus air. And by doing that, you would get a higher concentration of SIBO in that alveolus than you actually set in your vaporizer. You could argue, why don't you just set the vaporizer higher and not use nitrous? You could do that as well. Okay, but this is possibly clinically useful if you want to keep your SIBO on the lower side, but then have an effective higher concentration. Any questions about this? Because I know it's kind of a nebulous topic. No?
So once you've like reached equilibrium with the blood with the nitrous, does that go away?
Yeah.
Does that make sense? So
Yeah.
it's only in the first couple.
Exactly.
Okay.
Yeah, you have to have that AB gradient so you have massive uptake in order to get that massive refill that causes that effect. Yep. All right. What do you guys think? Mm-hmm. So what's the definition of MAC?
Minimum alveolar
Oh, that's what it stands for. What's like the definition though?
It's like the concentration which 50% of the population is inert to surgical stimuli.
Exactly. So they don't move to response to surgical stimulation. What do you guys think the standard deviation of MAC is? 0.1. Yeah. So 0.1. What do you think the E95 of MAC is? 1.3. Yeah. So 1.3 MAC should prevent movement in 95% of the population. That's assuming they don't, smoke pot like everybody else in Colorado and drink a bunch of beer, and they're also not on fentanyl, Versed, and ketamine, Presidex. So whatever. But it's 1.3. So there are genetic, pharmacologic, and pathologic states which affect MAC. What do you guys think?
Sure.
Obviously, yes, true. Okay, now this next slide, I don't want you to think badly of me, but I tried to create a visual, okay? So don't think badly, but here it is. Okay, so this is the things that decrease your MAC, okay? So an acutely drunk, high on heroin, pregnant woman who was unfortunately stabbed in the winter. So she's hypotensive, anemic, cold, and developing acidosis from sepsis. Okay, if you all those things together, all those things decrease your MAC, okay? I don't condone stabbing people in the winter or whatever. I don't want you to think I'm a terrible person, okay? Here's the increase in MAC, okay? A partying redhead who likes cocaine and meth and can drink you on the table and is coming in from a hot day, which went for a run because his thyroid's on fire, okay? So all of those things, yes, those affect your MAC. Okay, other tidbits which don't fit the visuals. MAC decreases with age but has these random spikes at 1 year and 40 years. SIBO's a little bit different because there's a third spike in there. You can read about that later. And then duration of anesthesia, gender, sex, or size don't change MAC. There is a couple studies which show that maybe there's a little bit lower in some elderly Japanese women versus men, but it's not a huge difference. I have an attending named Jake Friedman who's told me to give the patient what they need. So frankly, everyone's a little bit different, just give them what they need. But you should have an idea where they are in that spectrum based upon your baseline knowledge here. Okay, so from high MAC to low MAC, meaning high concentration to low concentration. You're looking at bar, awake, 1.0 and aware. So what's the answer here?
What's bar?
Oh, blunt autonomic reflexes. As you might imagine, that's kind of high. So it's A or C. What do you guys think? Someone said C. Good job. So bar is about 2.0, and 1.0 is obviously 1. And then the point of this is that awake and aware are two different things. And the body is awake before the patient is aware, okay? So that's when you'll have things like patient will move to surgical stimulus, and that's a response, but they're not necessarily awake. Or when you wake someone up in a case, hey, Joe, open your eyes, lift your head, squeeze my hand, whatever, and Joe's talking to you, and Joe doesn't remember that, and for like 15 more minutes into PACU. And he's like, oh yeah, I woke up in PACU. Well, we all know he woke up in the operating room in terms of like physically moving his body, but his brain wasn't fully awake until he was in the recovery area. Mac is added. What do you think? True or false? True. Yeah, that one's a low hanging fruit. All right, we got 10 more minutes here. We'll get you out of here. So nitrous. There's a couple of fun facts about nitrous. There is some controversy in terms of its B12 involvement, or I guess interference, which can be important in embryonic development. There's some thought that it increases your PONB, and there was a trial called your Enigma 2 trial, which retrospectively showed that if you use nitrous for greater than 45 minutes, you had a small increase in your PONB risk. It is retrospective, it's a secondary analysis, there's tons of biases here, okay? There's no randomized controlled trial looking at nitrous and nausea risk, okay? If you guys find it, let me know, because I'm going to put it in this presentation, all right? But important things about pressure. And these are kind of nice little numbers here. So if you use 50% nitrous, it increases your pressure by basically 0.5 ATM, or 50 hundredths of an ATM. So it's kind of a nice 1-to-1 ratio. 75% nitrous gets you by 0.75 ATMs. Okay, so you guys know that nitrous goes into closed spaces, so it's very bad. And anytime you're going to have an air space and a closed space. So venous air embolism, bowel obstruction, thorax. With a post-retinal attachment, they put a little gas bubble in there sometimes, and so that's probably not the best thing to put pressure in the eye more than they want it. It does have NMDA action, which is nice. Okay, so NMDA is one of those things we use for perioperative pain control, and it will provide that as well. Because its MAC is 105 or something %, you can't use it as a solo anesthetic at normal atmospheric pressures. Okay, if you put something in a non-hyperbaric chamber, you can use nitrous as your sole anesthetic. Okay, we don't do it, but it is theoretically possible. For adults, I use it for difficult IV placements, and so if someone's been stuck, 3, 4, 5 times in pre-op, sometimes I'll just say, hey, we're going to head back to the OR, we're going to give you some laughing gas to the mask, and we're going to put this IV back there, okay? With laboring mothers, you can actually use nitrous via a self-delivery system, so literally mom sits there and breathes nitrous through a mask, through a one-way valve, she breathes in, and when she gets enough nitrous on board, she gets a little sleepy and she'll drop the mask goes to the side, she'll breathe off the nitrous herself, and then when she's awake enough, she puts the mask back on again. If you can time your contractions, and if you're a motivated patient, it's actually a pretty good system. If you're someone who's wants to do it to avoid an epidural, you're probably not going to succeed. And the data says you're going to fail about 80% of the time if you consider family moving on to an epidural. Okay. It has less total lysis than our vapor, so it's used in postpartum hemorrhage. So if you have a bunch of uterine atony, so a big, floppy, boggy uterus that's bleeding, instead of using air inhaler anesthetics at a high dose, you can use nitrous. Propofol is also good in this situation. Remember that there's no oxygen in nitrous, and so if you're doing a wake up on nitrous from 80% nitrous, you're only on 20% oxygen, guys, okay? So you really aren't filling the tank pre-oxygenation. And if something happens, you got less time to respond to an airway issue if you try to monkey around with nitrous, okay? And there was one fun trial which showed that if you run SIBO or ISO for hours and hours and hours and then switch to nitrous and wake up on nitrous and get faster, it's like a nitrous washout. Per that trial, there was no difference in wake-up times. You're going to meet people who swear by this, and that's fine. Go with it. Don't say anything bad about it. Just do it and learn it. But realize that the data doesn't support doing that at the moment. All right. What do you think? It's actually true. Yeah. So check this out. So look at the heart rate. It increases about 10-15 points over the course of 8 hours. So, and the idea there is it's through parasympathetic ganglion inhibition over the course of that time period. So how do they cause hypotension?
Multiple causes.
It is multiple causes. Now this chart's going to say mostly PVR, which is also SVR. Okay, but the truth is that they actually have myocardial depression as well. So it's in both of those things.
What about long-term exposure? Like over time, if you have multiple surgeries, would that have that same effect? I don't know.
I don't know in terms of like in terms of the tachycardia effect.
Yeah.
I don't know. There's plenty of evidence looking at what happens to like what's a safe interval to do anesthesia again on people. We don't have a set interval. The truth is, if you need surgery day 1, day 2, day 3, you probably have a good reason for it. We have to do it. There's evidence looking at the pediatric population that if you do multiple surgeries on kids and you try to match them from a risk standpoint, that those kids have more psychomotor learning disabilities later in life. It's one of those things, again, it's kind of hard to tease out because obviously those kids are having multiple surgeries as kids for a reason. But if you try to case control them and kind of propensity match them, it looks as though anesthesia is not good for your brain. We don't have a set time period.
Have you ever done an animal study where they kept like an animal under anesthesia for like a week?
The what now?
Have they ever done like an animal study where you like keep an animal under sedation?
Probably. I bet Vesna's done it, honestly.
Who?
I bet Vesna.
Oh really?
Yeah, the chair.
What happens?
I don't know. Probably not great, honestly. You probably see neuronal death and slow wake-ups. But yeah, I don't know. It's good. It's a good question. Maybe you can do it. So what agent could, in fact, I guarantee you it's been done, so don't do it. So what agent could you add for additional hemodynamic stability? The answer is always going to be all the above, okay? So the truth is that any one of those things is probably better than increasing your inhaled anesthesia. Okay, so ISO can cause coronary steal. What do you think, true or false?
True.
So in theory, it's true. So ISO and halothane can cause coronary vasodilation. The truth is it probably won't be big enough to cause coronary steal. But in theory, they do both do that. Okay? At higher doses, inhaled anesthetics interfere with cerebral autoregulation.
True.
Exactly. Check this chart out. So your brain has the ability to auto-regulate between somewhere around 50 or 60 and somewhere around 150-ish, right? If you give them anesthesia at low doses, that plateau becomes a little more sloped. At moderate doses, it's a little bit higher. And at high doses, it's completely pressure dependent. So that's why I don't run a lot of gas for my neuroanesthesia patients. Okay, here's some pearls. Got 4 more slides. So nitrous, it can increase your ICP and thus your CMRO2. CMRO2 is your cerebral metabolism of oxygen. You can read about some fun EEG changes. They don't really have a whole lot of influence on what you're going to do for that patient. They have little effect on your evoke potential. So if we're doing SEPs or MEPs, nitrous is probably okay. But if it's any kind of brain surgery and you have pneumocephalus, the problem is that if you start to press the brain because of an increased pressure there, it can be lethal because you can herniate that patient inadvertently. We talked about kind of the adjuncts for analgesia over here. It's great for blood pressure support. You can actually do a sedation case with it. It's pretty few and far between, and you can use it in theory for your rapid wake-ups. With ISO, once you get to 2 MAC on ISO, you decrease your CMRO2 by 50%, at which point you're in isoelectricity, and you can't go any lower than that. The brain has the need to provide basically housekeeping, and so it's always going to consume some element of oxygen to make sure that those cells are alive. Even if the cells aren't doing anything, it's kind of like just keeping the thermostat like 60 degrees in the winter so the house doesn't freeze and the pipes don't freeze kind of thing. It's always going to have some energy usage. Okay. It does have a fluoride metabolite, which you can measure, and you can say, yes, it increases in 3. That increases your risk of renal toxicity, but clinically, not an issue. It is the cheapest anesthetic that we have. With DES, this is a theoretical thing. It increases your CSF production. It can cause burst suppression, but not isoelectricity. Carbon monoxide is an issue. It depends upon the type of absorbent that you're using in your machine. And other fun facts about DES, it's heated and pressurized, it's altitude compensated. It's nice that it has an alarm on the ventilator, or on the vaporizer. So if your DES starts to run out, that thing will start to blink and beep at you, right? So you can't like run out of DES inadvertently. Unfortunately, DES causes a lot of bad things. Number one, tachycardia is increased quickly. So if you just crank it to 12% DES right after induction, that patient's heart rate is going to go from 70 to 100, and you're going to be thinking, what the hell just happened? Allergic reaction, hypotension, yada, yada, yada. It also causes bronchospasm, so don't use it for asthmatic patients. It's terrible for the environment, which we'll get to later. Lastly, SIBO. So it can cause isoelectricity. It takes about 2 MAC to do it. It has this thing where it forms compound A, and compound A has been shown to be nephrotoxic to rats in a lab at crazy high doses of sevoflurane exposure, okay? So because of that, you have a recommendation from the FDA that if you're gonna run higher than 2 MAC hours, to increase your flows to 2 liters per minute, okay? So if you're running 1 MAC for an hour, you can run whatever the hell flow you want, okay? Because you're not at 2 MAC hours. 2 MAC hours means you're at a MAC of gas for 2 hours, or 2 MAC of gas for 1 hour. Does that make sense? So if you're doing a quick, simple case, you can put the SIBO at 0.5 liters. It doesn't matter. You can save all the SIBO that you want. It's just fine. In fact, over in Europe, they actually run SIBO at low flow all the time, and they are not having issues with people with having kidney dysfunction with some type of like ration outbreak. And then lastly, it is metabolized about 3%, and we use it for a lot of mask inductions. So it's 7 o'clock on the dot. We are done. Have a great day. Come at 3:15, and then we'll get out of here by 4, I promise you. Okay, guys?
Thank you. Thank you. You're welcome.